Hi everyone, welcome to the class. Hi Gabby, hi Niharika, hi Gifty, hi Kinjal, hi Mubaraka, hello Anjali, hi Meenakshi, hi Jasmine, hi Mubaraka, I'm good, thank you. Hi Ramona, hi Rosna, hi Harika, I'm good, how are you? Hi Jatinder, hi Binaya, hi Samina, Charmi, Rafaela. Something problem with my video today, so let me just share my screen. Can you all see my screen? Hi Nivedita, hi Nimra. Today we are going to talk about the smoking cessation guidelines. As you guys are aware that in our internal program and UAF 2 classes and UAF also, I have taught you smoking cessation guidelines as per Australian standards, the 5 A's that you have done with me, and we have used that to apply to the examination question so far. Anyone remembers? If you've done the program before, you've solved the UAF files with me, you know that we use that standard guideline and how it directly helped us to answer the questions that get asked in exam, and it practically works with every single question on smoking cessation. So far it has never failed, and no matter how complex ADC gave the question as, but it always worked. And you've seen that the clinical application, the practical application of those guidelines to the actual examination question. So I cannot speak much about it, that how great that guideline used to be. Now, when I say used to be, because it's a thing of a past, it's no more valid. I mean, there have been changes in Australian standards and guidelines and recommendations. And only last month in September 2025, not last month, like a month before, in September, they released the latest, newest smoking cessation guidelines. They're mostly on the similar lines, but they have concised it, they have made it more simpler and reduced the number of steps. Instead of 5 A's, they have made it to a 3A technique, which I'm going to be talking about today. While I talk about that, I will also, in brief, talk about the health effects of cigarettes and nicotine and tobacco products on general population, on pregnant people as well as the health effects of e-cigarettes, although we did talk about the vaping and e-cigarettes in the last class, but I'm going to brush up all those concepts again as well. The health effects of e-cigarettes, again on general population as well as on pregnant patients. So those are really crucial. So whenever the patient comes to you and they say that they vape, they use e-cigarettes, or they smoke, basically whether general population or pregnant patients, for all the patients you must ask. Actually, the guidelines in Australia say everyone above the age of 14, you must ask about the smoking history. So number one point to take is, if in examination it gets asked, what is the age from which you start asking the smoking history? It is from the age of 14. Does that make sense for everyone? So kind of like adolescence. Adolescence starts from 13. So anyone who's 14 and above is where you are going to start asking about the smoking history, right? Is my screen visible for everyone? Or is it just Anna, you that you can't see? You can't see my screen? All right, wait a second. Yeah, that's my screen practically. I'm gonna switch to the slide. So you were seeing my screen, right? All right, no problem. Yeah, I'm just gonna move to the slides, but I was just giving you the introduction, what we are going to be talking about. So I'm going to be discussing the health effects, and they come directly as questions. Mubaraka, you can do without my face. Trust me, the slides are far more interesting. I'm gonna help you in exam. So we're going to talk about the health effects, and we're going to talk about the 3A technique, how to help someone quit. I'm going to take you step by step how you're going to ask questions from your patient and why that's important, because ADC gives you such close options in the examination, where what will you ask first, what should be your advice first, and in the smoking cessation questions, every option is mostly correct one. what I've seen so far, only rarely one or two options would be like absolutely incorrect or would not be suitable. Otherwise, in such questions, usually what I've seen is that almost all the options are correct. And at some stage, they have to be said to the patient. So, what really matters in this guideline is, and what really, how you can really master this concept is by knowing the sequencing of what gets asked first. And in the question, whatever is already asked, considering that, what would you do next? Is it making sense? Sounds like a very tricky thing to say, but if you have done my course and you are part of my course, you know what I mean by that. How we analyze this, what has been done so far, and what would be done after. The sequencing of or triaging the questions, right? Making sense for everyone? Please type yes or no's if you know. That's tricky part, because sometimes sequencing wise in options something comes first, but that has already been done in the patient's history or in the question, so you also have to consider that and then choose a second sequence, right? So I will be showing you the flow chart again, the new flow chart again, the 3 A's now that they are not 3 A's, it's actually 3 step now, 2 A's and 1 H. So AAH initially used to be 5 A's. After telling you, and I'll tell you all the 3 steps, which is ask, advise, and help. Very important concept in smoking cessation is also what? Your timeline of the health benefits. Yes, Grisha, I'm gonna go to the slides. I'm just giving you an overview of what's coming your way. So, what are the timeline of health benefits from smoking cessation? That question also keeps showing up in the examination. What would be the immediate effects, the benefits of smoking cessation? What would happen within a week? What would happen in 2 months, 6 months, 1 year, 2 to 5 years, 10 years, or even in 15 years? So, timeline starts from the first few hours till after 15 years. So you do not follow the 4 old 5 A's from now. Nivedita, I checked all the questions from the previous files where the smoking cessation questions were asked, and I applied the latest steps also. Nivedita, so I did all the skimming of the questions which came till now on the smoking cessation and where we had applied those 5 A's. And then I thought that if I apply the newer guidelines and if the answer changes, then I must add them on the correction file. But we figured out that all the answers still remain relevant. So what has happened really is that the sequencing hasn't changed, the approach hasn't changed. They have just concised few steps as a single step. All right. So that is why the answers will not change. They are still in alignment with the latest guidelines. But yes, moving forward, any new questions that we see in the UAF2 also, I will be referring to the latest smoking cessation guidelines. Okay, because I know how amazing these guidelines are, and they have helped us so much in the past as well. This, you know, I swear by, and at least 3 4 5, maybe 5 6 questions per examination get solved by using this guideline so easily. Then I will also brief you a little bit about the pharmacotherapy for nicotine dependence. I'll just give you the names of the drugs, because sometimes in exam they get asked, because ideally only GP prescribes the NRT patches and behavioral interventions and the pharmacological drugs used for the the curbing your cravings, for nicotine cravings, but they are only handled by GP. So they're not like really asked in depth, but should know the names of the drugs which are commonly used. And after that, one of the very favorite ADC style of asking questions in these smoking cessation is also that patient tells you they smoke, and then they will tell you the barrier that they are having. They will say that I want to quit, but I get so many cravings, so I give up. Then it relieves my stress, I can't give up. Or I don't know whether the treatment would be effective. Can I switch to the e-cigarette, right, for quitting? And what if it makes me put on weight, or what if I don't have support, or I don't feel motivated, and they say no, I don't want to, I'm not even dependent on them. And sometimes they say I get depression when I try to quit, so with various different scenarios you have faced and seen the questions like that, where the patient presents with different barriers. Is that correct? Have you seen questions like that? Because smoking cessation is when you ask and advise them also. Patients start presenting to you their barriers to quit, right? It's not as simple as ask, advise, and help. Sometimes there are barriers also that you have to overcome in the patient's head. Do you all agree with that? Have you seen questions like that in the examination in the UAF Megamaster also, that patients will tell you these are my barriers? I need first thing in the morning, so cravings. Then it gives me relieves my stress. Oh, I don't do that much. I don't think it's a challenge, or I did but I got back, so I failed. So there are so many barriers that they face, right? So ADC asks you what would be your strategy to manage their barriers. So I'm going to talk about the barriers also. So does that give you an overview what we are going to be talking about in today's class? Does that give you an overview? So health effects, then the three-step technique, the timeline of the health benefits, and the pharmacological management, and then the barriers in the patients and how you're going to support them. So that was a quick overview. Now you know what you're going to learn, and at the end of the class, what you will leave with. That's amazing, Mubaraka. So I thought it would be a good idea to just have a foreseeing of what's coming ahead. All right. So health effects of cigarette and tobacco, we know that usually these are very common, so commonly understood, but exam still gives you, questions on these. So these are basic concepts, must know, just giving you an overview. There are respiratory disease effects. So it can affect lungs and lead to COPD, chronic bronchitis, emphysema, and also can risk the lung infection and even worsen the asthma in some patients. There are definite cardiovascular disease that are direct effects of smoking. It can contribute to heart disease, stroke, and even peripheral artery disease by damaging the blood vessels, by increasing the blood pressure, and even reducing the oxygen flow to the heart. So these are your respiratory and cardiovascular effects of smoking. Then there is a direct link of smoking as the leading cause of various cancers, including the lung cancer, throat cancer, mouth cancer, esophagus cancer, pancreatic cancer, bladder, kidneys, and even cervical cancer. So all these cancers have been linked with smoking. So not just lung cancer, but please know there are multiple other cancers which are highly, and it is a leading cause. It's a number one cause of cancers right now. So, what is the reproductive effect of smoking? So, women who are in the fertile age, it can cause them fertility issues, and it can also create complications during pregnancy, especially when they are smoking while they are pregnant, and increases the risk of preterm birth, low birth weight, and even stillbirth. And in men also, it can cause erectile dysfunction and reduce the sperm quality in men as well. So it affects the fertility and reproductive organs in both men as well as women. Then comes your GI effects. So there are also direct gastrointestinal effects. It increases the risk of developing stomach ulcers, gastric ulcers. Acid reflux is linked with it, and cancers of stomach, liver, and pancreas are also highly linked with smoking. It can also increases the risk of osteoporosis, and it can lead to weaker bones and increases the chances of fracture in patients because of the risk of osteoporosis. So this is not a very commonly known effect. Would you please remember this? It increases the risk of osteoporosis. Right? So women who smoke, they are already prone because of their fluctuating hormones as they age, and increasing if they're smoking as well. So there would be a higher risk of osteoporosis, higher pathological fractures, weaker bones. And there is also very not so commonly known effect, which is the vision effects. It can lead to the higher risk of cataract, macular degeneration, other vision problems that can lead to blindness, and weakened immune system makes body more susceptible to infections, slows the healing process as well. right? So health effects of cigarettes, this is direct cigarettes and tobacco effect on general population, on all the respiratory, cardiovascular, cancer, reproductive health, gastrointestinal health, bone health, immune system, and vision. Clear for everyone? So far, so good. If all these options are given, you would not be thrown away by the vision effects, by the osteoporosis effects. Yes, the other organs we still understood, but also fertility effect in the males. Those are less commonly known effects, but now you know everything. Tell me, is that completely clear for everyone? All right. So let's see what are the effects of cigarette and tobacco. I will come to the e-cigarettes in a while, but I'm talking general and pregnant effect of cigarettes and tobacco. Then I'll take general and pregnant in vaping. Okay. So in pregnant patients who smoke, again, just repeating myself, it's a risk of preterm birth, low birth weight, babies who are small for their gestational age, and perinatal death as well. And it can also lead to birth defects, cleft lip, cleft palate, and both can also be seen. So cleft lip, cleft palate is now commonly this was it was asked in the September 25 exam, so could be explored more in the coming exam or may not be as well. But so pregnancy smoking is linked with the higher risk of developing these birth defects, and definitely I'm going to take a class sometimes new and maybe in the next month talking about the surgical management of cleft lip and cleft palate as well. So smoking can also cause the premature rupture of membranes, like amniotic sac can rupture prematurely and can initiate premature labor. So it can lead to an onset of an early labor. And placenta previa is also a side effect, as well as placental abruption and separation of placenta from the wall of uterus. That is also a very common risk associated with smoking in pregnancy, right? So placenta previa, where placenta gets attached to the uterine wall closer to or over the cervix. So that's a high risk pregnancy, placenta previa, where it's facing towards the cervix. And then it's the placental abruption risk, which can lead to premature separation of the placenta from the uterus wall, right? So clear about the placenta previa and placenta abruption risk as well. And the birth defects, cleft lip, cleft palate, premature rupture of membranes like amniotic sac, uh, endometrial pregnancy. Deepika, I think you mean ectopic pregnancy. Ectopic pregnancy terminates really early when it gets in the fallopian tubes. uh, Closer placenta previa can complete and go to the full term, but it's a high risk pregnancy. Ectopic pregnancies do not last. In very early stages, they have to be terminated. But this is like the placenta implantation happened at a cervix level, which is very high risk because of the weight. It can lead to premature opening of the cervix and premature birth. That's why the bed rest is advised in case of those things. Okay. So that's placenta previa. And placental abruption again can disrupt the blood supply to the fetus, can also be extreme high risk situation. Right? So clear for everyone the effects of cigarettes and tobacco on general population and pregnant patients. And yes, guys, hot notes are coming on these guidelines as well. I will be adding everything on hot notes also. Once it's made, I will announce on the group as well once it's published. Okay. So latest guidelines will be covered as hot notes as well, will be added to your hot note collection. All right, so now let's talk about the health effects of e-cigarette use. If you watched the class last week, we did talk about vaping, and I'm sure you would remember some of these things. Hold on. Yeah. So e-cigarettes has chemicals and toxins. We talked about it in the last class also. Whether they contain nicotine or not, even other chemicals that they have, they are chemicals, they are toxins. They can have serious effects on the health, and which include that it can first of all lead to the nicotine addiction, nicotine poisoning, throat irritation, breathlessness, cough, dizziness, headaches, nausea, and lung damage. For young people who use vapes or e-cigarettes, it can cause serious changes in brain development, impaired attention, learning and memory dysfunction, and can also worsen their stress, depression, and anxiety. Yes, Raj. Now, it can also have effect on heart rate, blood pressure, arterial stiffness, and other risk factors which can lead to negative cardiovascular outcomes. Just like your regular smoking, there is now emerging research showing that e-cigarettes can lead to cardiovascular effects as well. Kidney disease as well, stroke and heart attack risk is also increased. It can also lead to oral mucosal lesions, dental and gum damage, oral microbiome changes, and it can have long-term effects also on the health, increased risk of caries, gum disease, and even oral cancers, right? And the health effects of cigarette use during pregnancy also brings the same effect, because nicotine in your e-cigarettes or vapes can easily pass from the mother to fetus via placenta. It is also again linked with your preterm birth, low birth weight, and small for gestational age, perinatal death. And they also contain chemicals and flavors and additives which are not suitable for pregnant women and can even harm the babies. Okay? And it can also lead to addiction and poisoning and nicotine toxicity in pregnant women and mothers. So that's why all your pregnant patients, you should ask for the history of both smoking, cigarettes, as well as e-cigarettes and vapes, and should advise on stopping and quitting the habit. Not actually worse, Samina. Cigarettes are really bad. E-cigarettes were considered safe few years ago, but now it has coming that they are actually as worse as regular cigarettes, Samina. That would be a correct statement to say. Okay? They are as bad as regular cigarettes because cigarettes are bad. They include tar and even worse chemicals than e-cigarettes. But now the research is emerging that e-cigarettes are as bad as regular cigarettes. Would that does that help you see the perspective, Samina? Got it? Beautiful. So that is the major learning in the health effects of e-cigarettes and there on the general population and on the pregnant population. Now coming to the most important recent change, which is the ask, advise, and help. So this flowchart is your new tool and new go-to for answering any quitting question. What should be the steps? So ask, advise, and help, right? You will ask your patient, start the conversation, and everybody knows that from the age of 14, this question should be asked from every patient. All right. So do you currently smoke? You would, oh, you want me to zoom? Okay, hold on, Jasmine. Hmm. All right. So you will first start, you will ask them, do you currently smoke? If they answer that no, we don't, then you will ask, have you smoked in the past? And they say no. So that means they have always been a non-smoker. You will congratulate them and confirm with them the benefits of being smoke-free. You will tell that it's great. This is the best way to maintain your health. Good going. Just stay smoke-free. So congratulate and definitely encourage the patients who do not smoke. Then if they say that yes, I used to smoke in the past, then you will ask them when did they stop. If they stopped long time ago, then again they have successfully quit, so you will congratulate them, follow the same, that yes, congratulate them and confirm with them the benefits of remaining smoke free. And then if they say, I have only recently quit smoking, then you will ask them that, okay, that's great that you have quit it, but do you need any help to stay in that quit? Do you need any help to stay in that smoke free? If they say, no, I don't need help, I'm doing great, I'm not having any relapses, congratulate them, confirm the benefits of being smoke free, and that's it. Now is the advice. If the patient says yes, or if they say, yes, I need help now, if any of these answer to any of these two questions is yes, then you move to the advice, because they want your advice. Because if they're currently smoking, or if they've only recently quit smoking but they need help, then you will provide your advice. And advice should be in a clear, supportive way without judgment. The most important thing you can do for your general and oral health is to stop smoking. You will advise them the adverse effects of smoking, the benefits of smoking, both. So you will tell them how smoking affects the individual person. In your mouth, these changes are visible. That's how I could tell that you are smoking. And of course, I'm concerned about your health, because smoking does this to oral health. Smoking does this to your general health. And smoking is a great risk for oral cancer, lung cancer. So everybody can apply the concepts which I just taught you, the health benefit, the health effects of smoking, and that is how you realize, right? That why you need to know the harmful effects, because your advice part cannot be explained to the patient without knowing the full-fledged harmful effects of smoking. Make sense? The puzzle fits, right? Does it or does it not? Right? Now, you will also advise the best way to quit and stay quit is the behavioral intervention. And the quit line and quit smoking services are available, which help you with the behavior management. They intervene with your behavior, they provide you nicotine replacement products and quitting medications if they are required. Clear for everyone? So, advice should be that yes, this is important for you, these are the effects, and this is the service number which will help you with the behavioral intervention, nicotine replacement patch, and no, there is a tone in a without judgment and without in a negative tone, Minakshi. So it has to be also in a positive and a supportive tone, right? Now comes with your help. So when you help them, after advising them, you will, how you're helping, you have advised them with the quit line number. Quit line number comes in the advice section. That part is clear? Quit line number, like giving them the advice on quit line and services, comes under advice. Health effects comes under advice, right? But the help comes, you're helping further by helping them arrange a referral to the quit line. By just giving the number is the advice, but by booking their appointment and arranging a referral, you are writing a referral, because when you write the referral, the chances of client uptaking that appointment is increased, and that improves their chances of quitting. So understood a very slight nuance difference. So exam can ask you what advice will you give or what help will you give. No, you don't, please. Right? Because those are available in your clinics in print. You don't have to memorize them. Now, difference between advice and help, please. Can you notice that advising that you need a behavioral intervention and a quit line service, and you need to go to the quit smoking service, and that you use nicotine replacement products and quitting drugs and medication, that's an advice. But when you make a referral, not just by providing number, but when you make a referral, that's your help. And when you encourage the use of, see, telling about nicotine replacement products is advice, but encouragement that use these and go to the GP, I'm going to make you a referral to the GP. Go and get your prescription. That's help. That's action. Advice is, yeah, you should get NRT, you should consider getting medication, and you should consider going to quit line. That's advice. But making, sorry about that. Yeah, sorry, the fire alarm went off probably by mistake. So, just advising them that they need this is basically just the advice, but you don't leave it there, and you need to help by making the referrals to the quit line and making the referrals to the GPs for getting them their medications. Offer supportive and self-help resources, and so that they can use the continued support even if they are not interested. So a lot of times patient may say, just a second. So this is how you offer them the help. So ask, advise, and help. All the three components are clear for everyone? So these are your latest guidelines based on which you will be doing the three-step smoking cessation guidelines for your patients. So how you're going to help them more, you will look for the opportunity to talk to your patient who smokes and then use this model to guide them. You will encourage and congratulate them if they have already quit or they never smoked. You will also give your patients all the evidence-based solutions which are part of the previous flowchart that we did. How come combination of behavioral intervention and quitting agents like nicotine replacement agents, nicotine replacement therapy, and pharmacological drugs, how it can help them. Then give them more resources for self-help, for staying supported and staying motivated. And you will document all the conversations and remember to follow up at the subsequent visits. This is extremely important, to follow up at the subsequent visits. It's not just first appointment when you educate them and it's done, right? Clear for everyone? So far so good. So health effects, all the adverse effects, and the three-step model is clear for everyone or not? So what are the basic recommended options? What are the basic tools to quit? It is your nicotine replacement therapy. It can be in the form of patches. It can be in the form of mouth sprays, lozenges, gums, and inhalers. And the drugs that are used are varenicline and bupropion. These are the two drugs which are commonly prescribed only by GPs. But ADC can ask you, gives you various drugs name and can ask you which of these are commonly used quitting medications. So know these two names, varenicline and bupropion. Can you remember these two names? And if other four options are given, this can become an immediate, straightforward, correct answer for you. Then the patch, lozenges, and gums, and all these quitting medications, they are eligible for PBS subsidy with a GP prescription, so they can get subsidy as well. And let your patients know that the GP or the pharmacist can provide support for their quitting journey, including the details that you will provide them. So GPs are the best to prescribe these quitting agents, and pharmacists as well, Grisha. Okay? No, you cannot. You can only advise and then help by giving them a referral. So your job is to refer as a dentist, right? You will refer to Quitline. They provide free specialist telephone counseling service, and your referral immediately improves their access to the support, and they provide them personalized plans. They also have been proven to be high level of satisfaction for all the patients who have used their programs. They have tailored programs for pregnant women and young people, and even with people with mental health conditions. Even interpreters and Aboriginal quit specialists are available. If you receive Aboriginal patients, then even the Aboriginal quitting specialists are special categories of specialists available, and they are, you can even refer them to the Aboriginal specialists. Only GPs, Nitya. You will secure online and fax referral options. You will refer for the feedback provided also, and all your health workers, if they come back to you and they ask you questions about the patients, then you will also help them with all those inquiries too. So this is your role in helping them to refer to Quitline, refer them to the GPs, and get interpreters for Aboriginal or language problems or Aboriginal quit specialists. And then you will also provide with the information for any health providers inquiries towards you. Does that make sense? What you're doing by helping? What are the steps that you're doing? These can all be in the part of the options. All these statements are given in the ADC options. You have seen questions before. This guideline always comes word for word. The options are made word for word from these guidelines. Okay? So words are really, really important. These are some of the statistics, how it has helped, just with the brief advice, how many people quit, with the NRT and medications, how many people quit, and with behavioral intervention, how many people quit. So definitely when you just advise, the chances are less, but when you add NRT and medication, the chances improve. And when you add the behavioral intervention, again, it improves. Now comes the most important concept, which is also in exam asked. What are the timeline of health benefits from smoking cessation? So, as I told you, it starts within hours and continues for 15 years. And ADC can ask you for any number of time which you must know. So within hours, as the patient quits smoking, within hours, they will start seeing the benefits, which is that their heart rate will slow down and their blood pressure will decrease. These are the two immediate changes within the smoker's body within hours of quitting. Can you memorize this table, please? It would be added to this hot notes. This you need to memorize based on hours and days and weeks and 2 months and 6 months and years and 2 years and then 5 years and 10 and 15. So within hours, heart rate slows down, blood pressure decreases. Within a day, almost all nicotine will be flushed out of person's bloodstream and their level of carbon monoxide will drop to normal levels. Oxygen can also reach more easily to the heart and muscles. So within a day, so many benefits start appearing. Within a week, the lungs' natural cleansing system will start to recover and improve, and their taste and smell will also improve. Within 2 months, their coughing, their wheezing will decrease, their immune system will begin its recovery, and their body will get better at fighting infections, and their blood will be less thick and sticky, and blood flow to the hands and feet, extremities will improve. Within 6 months, their lungs will work much better and produce less phlegm, and a person is less likely to feel stressed than when they were smoking. After 1 year, lungs will be much healthier and they will be breathing more easily if they had kept smoking. Their risk of cardiovascular disease and stroke will reduce by half. Within 2 to 5 years, the risk of heart attack and stroke will be lowered and will continue to decrease gradually. For women within 5 years, the risk of cervical cancer will be the same as the woman who has never smoked. So these are the cancer and the heart disease, heart attack risk and cancer disease risk will be seen at within 2 to 5 years. Okay. Then after 10 years, their lung cancer risk will also drop by half. Their other cancers risk will also drop by half. And in 15 years, the risk of heart attack, stroke will be close to that of a person who has never smoked. Right? So these are the timelines which you have to memorize. These are asked directly as the questions. Now, what are the three pharmacological agents which are used is your NRT, which is your nicotine replacement therapy, then varenicline and behavior interventions, and oral NRT if required for cue-driven craving. So NRT can be as patch, topical, or your also can be used as oral NRT as your lozenges or pills or drugs, tablets. Then bupropion plus behavioral intervention and oral NRT if required for cue-driven cravings. So these are combination when you're using pharmacological either varenicline or bupropion, you use it with behavioral intervention and oral NRT for cue-driven cravings. When the cravings are extremely strong, these can be used. And NRT alone with behavioral intervention is usually your first line. Oral or patch, but with behavioral intervention is your first line mostly. Then a GP can choose to add varenicline or bupropion. Is that clear for everyone? What is the first line? And then a GP may add it even in the initial cases also, depending upon if they seem to think that it's required in the early stages also. Now, the most important concept which I said, that SBQ gives you these questions which are under your health promotion and professionalism cluster of what the barriers. Yes, it is also available as spray, lozenge and tablets and So now what are the patient's mental barriers that you have to overcome and what are the advices that you will give them? So if patient tells you, I cannot quit because I have prolonged cravings or my withdrawal symptom gets too severe and then I have to pick up one cigarette again, what would you tell them? Well, you will tell them that they should use NRT or even approved pharmacotherapy. They cannot quit just by behavioral intervention. They cannot just use willpower. They have to supply the NRT. The nicotine has to go in the bloodstream to suppress cravings. That's what NRT does, right? When nicotine is in the bloodstream, it suppresses the withdrawal symptoms. It suppresses the cravings. So they cannot do just by willpower. They require NRT and or pharmacotherapy. And if they're already using NRT, then make them talk to the GP. Do they require higher dose of NRT or do they need it as a combination therapy of NRT with varenicline or bupropion? Clear for everyone? Advice for the first barrier when it's just because of the cravings and the withdrawal symptoms. Then your pharmacotherapy is there as a savior. You should promote that, right? One thing they say is that I enjoy cigarettes. I enjoy using e-cigarettes or cigarettes. Then you use, because that's a behavioral challenge, you use your motivational interviewing techniques to explore with the patient what they like about it, right? And what they do not like about it. And then motivate them and that would require behavioral intervention. Then if they think that they don't have knowledge of effective treatment options, you will provide them. So they say, I want to quit, but I don't know what are the options available for me, right? In the examination, you can get a question like that. I want to quit, but I don't know. So there is a limited knowledge that what are the options available for me. So in that case, you will provide them education, support, and you will provide them the additional information, quit line numbers, referrals, and then make them talk to the specialist there. Then they say, I use it, but I use it to relieve my stress. Then you have to debunk their myth that it does not help with relieving stress. And they can explore other ways of coping with stress. Does that make sense? It's the barrier and the advice matching the barrier. See, all advices are good. And in exam, you will get all the advices as the options. Now, based on the barrier, you have to choose the advice. Does that make sense or no? And these options will not be still, even if all the advices are given and there will be one barrier, still the options will not be very different. They will be only one word difference, keyword basically difference that you will require them to. So you will have to choose the option that fits most and which addresses most their barrier. That is all decided by GP, Daniela. The prescription is the strength and the length of the treatment is decided by GP, not us. And it can vary for patients. Now they may want to quit, but they fear the relapse. So then you tell them that they can even go for ongoing support. There are also support services available that even after they have quit, they can continue with the ongoing support. And you tell them that most people who quit successfully, they have tried at least multiple times before being successful. Now, anyone who remembers, this was one of the classic questions, failure, fear, and we had answered that in our MMF file, Gabby, yeah, or UAF. It's a classic ADC question. Now, in the guideline, this guideline, earlier we never had a guideline. If you remember, we only used to do it and mark it based on our some of the other NCBI articles that I showed you the reference, but it was not a very Australian reference or a very specific one. But this, with the Australian NSW Health Services released the guidelines and they published it there. If you remember, I showed you the reference for the same, that 80% of the people who quit, they failed in their first attempt. That was but one of the NCBI's article, but not Australian. But we used that as our reference and we chose that answer. But this time in NSW guidelines, they have put it under these tables. When the fear is of failure, you will ensure and you will tell them that it's clearly given that you will tell them that most people who have quit successfully have tried it multiple times before being successful. It's the exact printed sentence. Okay, you will tell them how to identify your cues and triggers and then how you can deal with your triggers. Okay, then flagging motivation or feelings of being deprived, then reassure the patient that these feelings are common. Remind the patient that even one puff of a cigarette can increase their urge to smoke, making the relapse more likely. You'll recommend that they should set measurable goals and use positive reinforcement, including rewards and incentives for periods of abstinence, right? Now, one of the other very common concern is the patients think that they can gain weight if they try to quit smoking. So it's one of the common side effects. So you reassure that the weight gain from smoking cessation is usually very modest, between 2 to 3 kgs. It's present, so you don't deny it, okay? You acknowledge it, but reassure that it's only very modest 2 to 3 kgs weight gain, and their main focus should be on quitting and by maintaining healthy diet and lifestyle and discouraging very strict low dieting, but they can manage the 2 to 3 kg weight gain. Okay. Sometimes they may say we don't have the support system. Then you tell them that they can come to a trusted health professional. You will make them a referral for such quit lines and support specialists. And you will tell them to identify their sources of support in family and friends. And you will also definitely send them to the quit line, because the quit line, you'll make the referral, they have the professional support providers and they provide the behavior intervention and they also help with the maintaining and sustaining the motivation. Then they say, I get in a negative mood or depression with withdrawal. So then again, you will tell them that you will refer them to the GP. And if they need any mental health support also, you can even refer them to the mental health support lines. Then they can say that my friend circle, there's a peer pressure, they use e-cigarettes or they smoke. Then you again encourage them to enlist support from the friends and the family members who do not smoke, and spend less time with people who smoke. But they tell them that they're trying to quit, so offer them again support, and they can request their friends that at that time that not to smoke or not to use the e-cigarettes while they are there. So that was the last aspect, and these are the exact questions how ADC asks you the health effects, the asking, the advising, the helping, knowing the benefits of quitting, and then what are the mental barriers, because that is a very classic question framework. What are the barriers? How will you support in helping with their journey? So thank you so much, guys. I have one announcement that soon you will know the December public mock will be coming, and the December public, and then our Ninja mock, Ninja level 2 is also going to get released, right? Next Friday. So you are looking at two mocks which are coming up, and then anyways you're taking your subject wise weekly mocks. We are in week 7, so you have it till week 8 also. So there are so many mock experiences. That Binaya, that was out in October, Ninja 1. Ninja 2 will come in November end somewhere. And then the public mock, December public mock is coming, which is absolutely free. But December public mock will have a syllabus. It would be based on our previous public classes. So if you are not enrolled with us, you can watch our previous public classes. I will soon create a post listing the classes and putting the links there, which would be the part of the December public mock syllabus. And if you want to join our course, we still have greater discounts available. We are in week 7, so definitely there is a lot to catch up. You can still cover up with the backlog. We have our weekly 3P sessions, bi-weekly 3P sessions, where we help candidates who enroll in the middle, or they're joining in the week 2 or week 3 or week 4. So anyone who joins after the course has begun, that's why we have bi-weekly 3P sessions, where we help you plan and where we help you set up a purpose and then see that as your progress. So that's your 3P class and session, where we guide you to plan, set a purpose, and then achieve your progress. And so do not feel that if you join now, you will not be supported. The full support will be offered, and 3P session is especially there in place to help candidates who join at week 4, week 5, week 6, or week 7. So lots of mocks awaiting you coming, and there's so much excitement for Ninja Mock 2. And then there is a December public mock, entirely new SBQs on latest classes. Before I take the December public mock, I have another class, public class next week. So probably I will take another academic session or something else for the help. Let me think on that. But that will also be part of your December public mock if it is an academic session. All right. So thank you so much for being the fabulous audience that you always are. And I hope you enjoyed the latest guidelines, and I hope you feel supported, and I hope you feel confident that Winspert always got you. We always bring in the latest guidelines. We never leave it on chance. We never leave it okay, we see the question and we are not even aware. We are regularly on a lookout for all the latest guidelines, all the latest changes in the Australian recommendations, and we make sure we go through the older questions, we make corrections, we add to the correction file as and when references get updated. So we bring that level of transparency to our course. We never hide, or we never shy away from accepting that yes, this answer has changed because this new guideline came, because this new reference came, or a better reference came. That's the level of transparency we offer our students. That's the level of transparency you deserve, you need to crack this examination. And that's why Winspert always gets the highest number of candidates cracking the ADC exam, and we are super proud of you all. Thank you so much for making that possible for Winspert, and I'm really, really grateful for you all. You guys are what I live for. Thank you so much. Have a fabulous evening. The Hot Notes HODA will be made available in few days. It will be announced on the WhatsApp group when the Hot Notes on these guidelines are ready and are published on the app. Thank you so much, guys. I'm extremely grateful to you all. See you tomorrow in our Ultimate Advanced File Volume 2 session. We are going to do more pedo and ortho questions. Gonna have such a great internal class that we always do. Have fun while learning. Have fun while we grow together. Thank you so much. Have a beautiful evening, and truly grateful. Truly, truly grateful for you all. Thank you. Bye. See you in the next class, Binaya. Thank you so much. Thank you. Bye, guys.